Hello, everyone. Thank you for joining us for the ADAA webinar series. I'm Dr. Jenny Yip, and I'm the Executive Director of the Renewed Freedom Center for Rapid Anxiety Relief and a member of the ADAA Public Education Committee, which produces this series of monthly webinars. Among other involvement, I'm also a clinical assistant professor of psychiatry at the University of Southern California Keck School of Medicine, Child and Adolescent Psychiatry Residency Program. We'll be able to answer some of your questions at the end of the presentation. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of that panel, and when you click in it, you can type in a question. Then either hit your Enter key or click the icon. You can ask questions at any time, and we'll try to get to as many as possible. Other participants cannot see your questions. We may not have time to get to your individual question, so we apologize if that is the case. We'll also be recording this webinar to make it available on the ADAA website at a later date. We are broadcasting, so we cannot control your individual audio or visual computer settings. Today we'll be hearing from Dr. Daniel Lewin, Associate Director of Pediatric Sleep Medicine, Director of the Pulmonary Behavioral Medicine at Children's National Medical Center. He's also the Assistant Professor of Pediatrics and Behavioral Medicine, George Washington University School of Medicine. Before we begin the presentation, I'd like to tell you about ADAA. It was started in 1979, and today it is the leading nonprofit dedicated to increasing awareness and education about anxiety disorders, depression, OCD, PTSD, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they are real, serious, and treatable. Please visit the ADAA website. That's www.adaa.org, which includes Find a Therapist, a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Remember, you can type a question at any time. Now let me turn it over to Dr. Lewin.
Hi, thank you very much. Thanks for the opportunity to speak to your group. So I'm going to be talking today about sleep disorders in children with anxiety and depression, with a primary focus on the assessment and diagnosis of sleep disorders. But to put it all in context, I also will touch a little bit on the association between sleep disturbances and affective disorders, and also on basic concepts in sleep and circadian regulation. So, sleep disturbance in children is well characterized and associated with psychiatric disorders. So this is a graph of a group of kids who are diagnosed with psychiatric disorders and who are part of a study. And these are the various types of sleep disorders they have. Insomnia is highly prevalent. We'll talk about the definitions of insomnia. See nightmares in this group, parasomnia, sleep disorder breathing, excessive daytime sleepiness, and various other behavioral problems associated with sleep. There have also been several studies, an increasing bunch of studies, looking at the associations between sleep disturbance and psychiatric disorders. This graph illustrates a psychiatric compared to a healthy comparison group and various key metrics that we use when we're evaluating sleep, sleep quality, etc. So the psychiatric group had shorter sleep. Their sleep onset latency, the time that it took to fall asleep, was longer. Just focusing on key variables, the minutes awake after sleep onset were higher. Number of awakenings were significantly higher, and their sleep efficiency, which is a ratio of time asleep to time in bed, which is an important metric for characterization of how efficient the sleep period is. So there's a long history of studies looking at the association between major depressive disorder and anxiety and sleep disturbances. Anxiety, there's increased awakening and sleep onset latency in individuals with anxiety, with subjective reports of sleep onset latency, and decreased delta sleep, which is one of the deeper stages of sleep that occurs at the beginning of the night. Major depressive group exhibited less time awake than the control group and less stage 1. The analysis of demographic and clinical characteristics revealed that about 50% of the 46 patients had a professional diagnosed psychiatric disorder that was previously established. So we have this strong association. The association, however, is complicated. There have been various studies that have looked at underlying causes, psychophysiological causes, hormonal changes, and it's been relatively hard to land on just one or two. So in some cases, it's more a report of poor sleep quality. In some other cases, it may be underlying issues related to regulation of serotonin, norepinephrine, dopamine, etc. So most of what I talk about will now be focused on sleep and on the treatment of sleep disorders and their diagnosis. And this is all relevant to and can be combined with standard ACT, behavioral, cognitive behavioral interventions that you would typically use with anxious or depressed patients. So definition, sleep is a reversible behavioral state of perceptual disengagement from and unresponsiveness to the environment. That is pretty much what we observe of sleep. However, we're now really understanding in a very rich and deep way biologically that sleep is also a complex amalgam of physiological and behavioral processes. Interestingly, just in the past 5 years, it's become clear that every single cell in the body and brain has clock genes, and these clock genes regulate critical aspects of cell function. So sleep is really absolutely necessary for much of our biological function. We know little, though, however, now about the contribution in development. So just to give you an idea of what the brain looks like during sleep and how variable the states or stages of sleep are, these are each traces of EEG located in one region of the brain. Awake, you see a very random fast pattern. As we close our eyes and become drowsy, we see an alpha pattern. There's further slowing as we enter stage 1. The stage 1 is when we are just drifting off to sleep. If you were holding a ball as you were falling asleep, you might drop the ball and be aware of dropping the ball, or you might have a jump or a jerk, a large body movement as your body's letting go. We spend just a few percentage points of the night in stage 1. We then go into stage 2 sleep, where we spend about 50% of the night. This morphology is not worth going into in this brief talk, but stage 2 sleep is prevalent throughout the whole night. We then have stages, what's now just called stage 3, non-rapid eye movement sleep, and these are delta waves. And this is really a representation of a broad synchronization of firing rates in the cerebral cortex. You can see that we really have very, very dramatic differences. Finally, rapid eye movement sleep, and I'll describe these in a little bit more detail, looks very much like awake or stage 1, where the brain is extremely active. So throughout the course of the night, we cycle in and out of different stages. So children tend to have shorter cycles than adults, about 60 minutes. Adults cycle between stages in 90 to over 100 minutes. So we begin at wake. This is time across this axis on the bottom here with 2200, about bedtime, perhaps for a child or young adolescent. They then fall asleep pretty rapidly and go almost immediately into stage 3 or stage 4 delta non-rapid eye movement sleep. Then cycle up after about 60 to 90 minutes to rapid eye movement sleep period, back down to delta, and you can see that these cycles persist throughout the night. Really, after about 3 months of age, this is a pattern that is present throughout the whole lifespan. So after 3 months, we really see this very persistent pattern suggesting that what's going on during these stages is really critical for biological function. The other important piece of this that's important to note is the non-rapid eye movement stages are predominant across the beginning of the night. And I'll explain that a little bit more in terms of we have a homeostatic drive to go into the slow wave sleep. REM sleep, however, increases over the course of the night, both in depth, intensity, and duration. So we have our longest periods of rapid eye movement sleep in the early morning hours. Rapid eye movement sleep, we know, is absolutely critical for regulation of affective states. So this is about as complicated as I'm going to get, but this is a very, very important slide because in this slide you can kind of understand a lot of where sleep disorders have their origin. So process S, or the homeostatic process, and what regulates delta sleep and other stages as well. Here's time again across this axis, and this darker line here to the right-hand side is the actual sleep period. So over the course of the day after we wake up, we gradually just have an increased sleep load until we get to bedtime. And then as we sleep, that homeostatic load, the sleep load is decreased. We sleep through the night. The other process clock, or the circadian process, is really an alerting signal, and this repeats every 24 hours. So the circadian rhythm and the process sleep are intricately related. So over the course of the day, we have this increase in activation. It waxes and wanes a bit. There's probably a dip right here around optimal siesta time. And then at bedtime, we actually have a heightened peak in our level of activation. So for any of you who have children or who know children or observe them at bedtime, you can see that this high sleep load and a high level of vigilance here are problematic behaviorally. So with a high sleep load, we're a little bit disinhibited. We have trouble controlling our thoughts. And with a high level of activation, this is where anxiety can become particularly dominant, feelings of sadness, loss, depression, because we're not inhibiting as well as we might at other times of the day. So it's, again, this convergence that's problematic. And then as you're thinking across child development, the circadian timing of this alerting signal shifts. So younger children, the curve is shifted to the left, so they like to go to bed earlier and wake up earlier, whereas adolescents prefer to go to bed 10:30, 11, or after, and then wake up later in the morning. So that relationship of the circadian phase to the sleep load can vary tremendously across the course of the week, particularly in kids, say high schoolers, who have very early school start times that can start as early in some districts as early as 7:20. So here I'm showing just various estimates from a national poll, non-scientific poll, as well as some data from Switzerland on average estimated sleep times that would be optimal for individuals. So this is probably, the population data from Switzerland is much closer to what our actual sleep drive and optimal sleep need is, and the poll data represents how much kids are sleeping in this country. And I think we're pretty aware that sleep debt is a major problem in this country, and particularly in the context of understanding the necessity of sleep and circadian regulation for really function across all systems of the body, that we really need to focus on optimizing sleep and as healthcare providers really set an example and advocate for optimal sleep. So here I'm listing the various pediatric sleep disorders, insomnia being one of the most common and prevalent, psychophysiological insomnia, which can exist even in young children, and behavioral insomnia of childhood. And I'll give examples of each of these. And you can see that the prevalence ranges from 20 to 50%, certainly higher in psychiatric populations, as I pointed out before. And the behavioral insomnia is a smaller percentage, and these tend to be transient, but in some cases where they really are persistent, and there's a great deal of problems with parent-child interaction, they can lead to psychophysiological insomnia in the long term. Sleep-related breathing problems, critical that these are evaluated in any patient you see. The simple question that you can ask is, does the child snore? And if there is snoring associated with any kind of behavior problems, then it warrants a referral to a sleep lab or referral to an ENT, or at least back to the primary care pediatrician for further evaluation. Hypersomnias, these are Less common, narcolepsy is about 0.02% of the population. We don't have great estimates in kids, but there has been an increase in the presentation of narcolepsy. We've recently started a narcolepsy registry because we're very concerned about a real bump up in the frequency of narcolepsy. Circadian rhythm sleep disorders are really quite prevalent, about 16%. And these can range from mild preference for going to bed later and waking up later to a very rigid, biologically determined change or individual difference in how the 24-hour cycle is regulated from one part of the brain in particular, called the suprachiasmatic nucleus, which is innervated by light. Light, that's one of the first places that light hits in the brain, which kind of resets our clock time. Parasomnias are also relatively common. These are a range of disorders where the brain is part of the brain is deeply asleep and part of the brain wakes up. And these can be confusional arousals where a child wakes up for a short period of time, or an adult as well. Sleepwalking, sleep terrors where the child awakens typically with a scream and is in a very agitated state from a few moments to sometimes 15 or 20 minutes. And then sleep enuresis is also in this category. These can be associated at higher rates with anxiety disorders and depression. The mechanisms we're not exactly clear on, but I'll talk about it just a little bit. It's also important to know restless leg syndrome. We think about that as really occurring more commonly in adults, but it also occurs in children as well, and can both be associated with sleep disruption and delays in sleep onset latency, the amount of time that it takes to fall asleep. So a few principles as we're thinking about kids and evaluating them. A tired child does not look like a tired adult. A tired child can look sullen, they can look sleepy, but they can also look hyperactive and overactive and constantly on the go, which might be their way of fighting the tiredness and maintaining wakefulness. Or it may just be that they are not editing well their behavior or their attention because they're tired. The phenotype of the tired child and the child with ADHD, there's a great deal of overlap there. Neurobehavioral functioning should be a factor in intervention decisions. So in other words, if you find the child has sleep apnea or a bit of sleep disturbance, maybe just slightly decreased sleep for their age, and there's daytime behavior function, problems with affect regulation, then intervention really becomes more of a priority. Prior to the age of 10, children are unreliable reporters of internal states, and as child therapists, we're all very, very well aware of this issue. There's also a high comorbidity of sleep and psychiatric disorders in children, which I've already alluded to. So the behavioral insomnias of childhood, the first type, which tends to occur in younger children, is this should be 6 to 36 months. There's a prevalence of about 25 to 30%. The clinical features are delayed time to fall asleep and night awakenings. So falling asleep, very simply, the problem is that falling asleep becomes associated with exogenous cues. So the parent holding the child as they're transitioning to sleep, the parent feeding the child. So the cue must be present for the child as they're making the wake-to-sleep transition. And what's key to understand here is that that first transition to sleep is really the most important and what we tend to focus on when we treat sleep disorders. If you can break that association at the beginning of the night, then the rest of the night tends to fall into place in a relatively short period of time. It's also key to understand that the average human being awakens between 5 and 10 times a night between the sleep stages that we drift through. So every time a young child wakes up and they are accustomed to a certain cue at the beginning of the night, they'll signal or they'll look for that cue again in the middle of the night. So the other common type of problem in children is a limit-setting sleep disorder. Similar prevalence, and these are older kids, 18 to 60 months. You can't have a blend of these two, though. So the clinical features are delayed bedtime, and parents will tend to reinforce undesirable behavior at bedtime. So the child getting up, engaging the parent, more stories, oh, I'm scared, there's something in the closet, this is worrying me, I've got something going on tomorrow, more water, et cetera, et cetera. On and on it goes, however the child can engage the parent. And the more they become attached to this, the more intense and problematic the behavior can become. It's also important to think back to the slide that I showed you with that period of activation. Often, parents are fighting against a child who's having a normal period of circadian activation, which is a signal that they're about 20 minutes away from their optimal fall-asleep time. So conflict can develop between the parent trying to force the child into bed at the desired bedtime and the child really having a high level of activation that's being mediated by their circadian system. And we often point this out to parents. That period of activation is called the forbidden zone. So when we evaluate sleep problems, and I take this from Judith Owens and Jody Mendel's book, which is a great desk reference. I will disclose that Dr. Owens is the director of our program here, but I gain no direct benefit from pitching her book. So when we evaluate sleep, we want to focus on several areas. Bedtime. Is there a routine, and is the routine appropriate for the child? A surprisingly large number of children end up watching TV as they're falling asleep at night. Not always appropriate TV. Is there bedtime resistance? Is the child avoiding bedtime? Are there bedtime fears? And here it's very important to differentiate for parents and for you as clinicians that there are differences between, or we differentiate in this field between fears versus anxiety. So a fear is normal. Everyone has bedtime fears, in part because of the disinhibition and the circadian activation and the convergence of the two. However, anxiety at bedtime could be a simple anxiety where the child has had aversive experiences actually in the bed, and going to sleep is a scary period. But we tend to think of sleep-related anxiety as also being persistent anxiety during the day, and that shows up in other parts of the child's life. Or it's clear that the child is very anxious and that anxiety is interfering in other parts of their life. So again, important to differentiate fears, which can really activate parents, and anxiety. EDS stands for excessive daytime somnolence, tiredness, and that can look like a variety of behaviors in kids: hyperactivity, irritability, and difficulty waking in the morning. As I said before, young children should easily awaken between 6:30 and 7 in the morning. If they're sleeping in until 8, 9, or 10, that means they're not getting adequate sleep at night, or there's something off in their circadian regulation. Obviously, not difficulty waking in the morning is absolutely the norm for all adolescents, and is actually normal. So waking in the morning can be thought about developmentally, or should be. Awakenings, is the child calling out at night? Are they having partial arousal, or those parasomnias that I referenced before? And is there restlessness during sleep? Do they move around excessively? The regularity, is the schedule of their sleep regular, and is it age appropriate? So a 7-year-old being put to bed at 11 or midnight is clearly problematic. That's occurring on a regular basis. You can also not put an older adolescent to bed at 8 or 8:30 because they have to wake up, say, at 5 a.m. for swimming practice. They just cannot fall asleep that early. They're not biologically prepared to do so. And then snoring. And again, snoring is absolutely critical to evaluate. You want to ask about volume of snoring, pauses in breathing, and the periodicity of the snoring. Is it only associated with allergies, or only when the child is sleeping in a certain position? There are about 90 articles that have been reviewed, and there are several excellent broad reviews of behavioral interventions for children from birth to 5 years of age. Interestingly, the definition of insomnia for young children, aside from the behavioral insomnias, essentially does not exist, and this is really a huge gap in both our diagnostic book. Our version of the DSM is called the International Classification of Sleep Disorders, and there will be changes. There's kind of a consolidation of all the insomnias, which will speak to this point a little bit more of the lack of appropriate diagnosis of standard psychophysiological insomnia in kids. So this just reviews how many were reviewed in a particular review article. Jody Mendel was the primary author of this article. So when we're addressing bedtime problems, bedtime resistance, curtain calls, repeatedly engaging the parent, nighttime fears I've talked about, bed and crib aversion I've talked about, crying and tantrums occurring at bedtime. And again, we also want to be aware of nighttime awakenings, and these are also a target of treatment. So let me just pause. I want to take a step back here and talk about a couple of issues. So our brains are built for vigilance. We vigilance protects us and did protect us throughout all of human history. So letting down vigilance is, by definition, a very dangerous thing to do, and our brains do not want to do it easily. So the easiest way for us to sleep is like this family on the right. This is an Eskimo photograph of an Eskimo family from the 1950s where they're all sleeping together. About 75% of the world co-sleeps. And while there are safety issues in co-sleeping with infants, this is in some ways the normal state. But in the Western world, our sleeping arrangements differ. Our caves have become multi-room houses. And while you can convince the child and the family that those multi-room caves are just as safe, still sleeping right next to somebody is something that we've become accustomed to. It's very powerful. It signals safety and really facilitates letting down of vigilance. And when you begin to think about children with anxiety disorders, who have primary anxiety or who have been exposed to traumatic situations or events, then it's this letting down of vigilance where there is a great deal of difficulty and a lot of work can be done. So here I'll present the first case. This is and I want to present this tool as well. So this is a sleep log, and this is really a critical tool. I'm happy to make these available at some point via the ADAA website. There are also multiple sleep logs available online. So this just gives a very quick picture of how an individual is sleeping. So this is a 2.5-year-old boy. On this axis so this might be a Monday, and this is midnight. So crossing over to, this is Tuesday here. So the child so this is Monday. Here's midnight over on this side as well, crossing over to Tuesday on the second line. So this particular child is going to bed at approximately 12:30 in the morning. The mother was nursing the child here. She put an N for nursing. You can see that he napped here and napped again in the middle of the day around 2 o'clock. The next day he sleeps in, takes a morning nap, and then a long afternoon nap and has trouble falling asleep again at night. So the key issues to recognize in this 2.5-year-old is that he has a very late bedtime. He really should be put to bed around 7:30 or 8. He's extremely variable bedtime. So bedtime really should not differ for anyone more than about 20, 30 minutes a night. But you can see there's tremendous variability in his bedtime here. Also tremendous variability in his wake time. His mother he's nursing him to sleep here, had stopped nursing him in the middle of the night even at 2 years of age, which is a common problem that we hear about where parents are feeding the child throughout the night. And that's the first approach to solving a child's sleep problem, is addressing their nighttime feedings. But here she'd already stopped, and you can see a relatively well-consolidated sleep period in this dark shaded area. So this child is developmentally past the point where they should be taking 2 naps, but in essence, this mom feels that the child should be sleeping in later, so he's getting a morning nap, and in some cases, he's getting an afternoon nap, which is likely to push his bedtime later. And then on days when he takes that morning nap or is sleeping in, and then has to maintain wakefulness for an extended period of time during the day, he's in a bad mood, and he's very, very grumpy, but does not quite have the sleep drive. So you can see just from this very brief picture, this is very valuable information. And as with many of the questionnaires and self-monitoring techniques that we use, this often a parent will present and they'll say, you know what, the problem has been so much better ever since we started doing the sleep log, or ever since we made the appointment to come in. So what do we do with this child? First of all, we decreased the frequency and duration of nursing around bedtime, and we separated nursing from bedtime. So the mom could no longer nurse the child in the bedroom. We had them nurse outside the bedroom, and then they were allowed to go into the sleep environment. In this particular case, the dad had moved out of the bedroom. The mom had brought the child into her bed. You always need to be aware of marital issues and some other issues related to sleep that may be maintaining sleep problems. So in this case, we limited the child's sleep to his own bedroom and said he can only sleep there. The mom, in the meantime, can sleep in the bedroom or be there. So we gradually faded the parent's involvement in the wake-to-sleep transition. So you can take baby steps where the parent is sitting next to the bed, then moves their chair across the room and then outside the room and engages less and less and less. We also involve the father in the bedtime ritual to kind of bring him back into the relationship. You can also do the fast approach, and I'll talk about that in just a little bit, where it's basically a immediate extinction. We also introduced a transitional object, so a small toy, a blanket, something safe where the child isn't going to be able to bite off pieces, preferably an organic fabric, and something that can be washed hundreds and hundreds and hundreds of times, because often kids will have these transitional objects into later childhood, even adulthood. I'd ask you to raise your hands if I could, see how many of you actually still have your transitional objects nearby. And then there's limit setting during the day, and often these kids who have trouble falling asleep at night, Carl in particular, his mom was not setting and dad was not setting great limits, and this kid was having major tantruming issues. So treatments for the behavioral insomnias of childhood in general. We want to identify and eliminate the reinforcers or cues that delay an independent wake-to-sleep transition. We also want to develop positive routines, quiet behavior, reading together, cuddling together. If the child is becoming overactivated, either because they're anxious about bedtime or become hyperactive because of that forbidden zone, the circadian-mediated activation period, then maybe some quiet time alone is optimal to get the parents out of the scene, to kind of give both parent and child a bit of a timeout. Establish appropriate bedtimes for the child. So what is appropriate for a particular age group is critical. You don't want to have a child in bed much too early, nor have a child in bed for long periods of time awake, and that becomes more key with a more persistent psychophysiological insomnia. And then establish appropriate bedtime routines for the child's age. Extinction, simple extinction, or the quiet out technique, a lot of people attribute this to Ferber, where you basically, the parent just ignores the child's attention-seeking and inappropriate behavior and immediately withdraws whatever cue there is that has become associated with bedtime. This usually results in 2 to 3 days of crying and then pretty rapid accommodation and learning of the new optimal activity. And then we always warn parents, and unfortunately there's not enough of this in the literature, about an extinction burst, because about 4 to 7 days later, that parent is either calling us back or I'm sure they're cursing us, saying, why is this a problem again? That doctor didn't know what they were talking about. But if you can warn them about the extinction burst and they can push past that, as we're aware with many of the interventions that we do, they tend to do much better. Graduated extinction, also kind of Ferber's incremental approach, where there's a gradual or a highly routinized or very regular withdrawal of parental involvement. You can increase visit intervals to the child or decrease visit duration. There's also the quick check. There's a check-in versus the check-out, where the parent might hang out with the child and say, honey, excuse me for just a minute. I need to go talk to daddy, or I need to do something. Duck out of the room for less than a second, head back in. Good job staying in bed. I'll be right back as long as you're quiet. Go away for 10 seconds and then come back, and gradually increase the time of checkouts until the parent says, you're doing such a great time falling asleep alone. Now I'm going to check in. I'll be back in a little while to check in and see how you're doing and see if you're asleep. And most parents who end up in our sleep clinic are much more comfortable with this kind of gradual approach to removing themselves from the bedroom. There's also planned ignoring, with or without parental presence, either in or out of the bedroom. Okay, so I think I've touched on most of this already. There's one wonderful technique that we use quite often, the bedtime pass, and this is for slightly older kids, where you give the kid a token and say you can keep the token. It can be something with or without intrinsic value or symbolic value. You can keep it if you stay in bed. But if you need to come get us, check in with us, then you have to give us the token. This really gives the child control over the bedtime, and then they can collect these, and on some schedule that you or the parents determine, they can then turn in however many tokens for some other activity when they've made improvements. So fading approaches I've already talked about, decreasing parental involvement gradually or quickly. So psychophysiological insomnia, which we really believe can occur even in young children. There may just be some individuals who have a 24-hour cycle of hyperarousal where they just have trouble letting down and letting go. Maybe not associated with anxiety, but in some cases may be associated with anxiety, sadness, or depression, just difficulty inhibiting negative thoughts. Some people define insomnia, at least some kinds of insomnia, as inability or unwillingness to tolerate being in bed for an extended period of time. So difficulty falling asleep at night, with a sleep onset latency of greater than 30 minutes, occurring more than 3 times a week, difficulty staying asleep at night, so waking up in the middle of the night and being awake for more than 15 to 20 minutes, subjective report of poor sleep quality. And this is a little bit tricky. So you might be going through a very stressful period and feel like you just didn't sleep at all one night, that your mind was working on something all night, or you were grading papers, or you forgot something about a patient, and your mind works on that. So there are various types of subjective report of poor sleep quality. There is one called sleep state misperception, where you perceive yourself to be awake, hyper-aroused all night, where you're really not. If you were in the sleep lab and you were evaluated, then it would really, the sleep test would show that you're asleep at night. And then a report of impaired daytime function. So whatever sleep disruption there is impacts function during the day. I will take a step back and just say that sleep studies, overnight polysomnographic studies, and I don't really have time to focus on them, the primary reason that you refer somebody for a sleep study versus a sleep evaluation is to rule out obstructive sleep apnea syndrome. That is almost the exclusive reason why there are also to rule out narcolepsy, sometimes periodic limb movement disorder, persistent sleep disorders, or a sleep-related seizure disorder. So here I'm presenting a typical presentation on a sleep log, again, with time across this axis here. So this is Thursday at midnight, going over to Friday, early morning hours, 12, 1, 2, 3, 4 a.m., etc. So what's key here in this adolescent is that they're trying to go to bed at around 9 p.m. And clearly for school, they have to awaken at 6 a.m. So this would give them about 9 hours of sleep if they could fall asleep, which is really what they need. But an adolescent is going to have trouble falling asleep no matter what at 9 or 9:30 at night. So this individual gets into bed, they lie around. She was worrying, she was trying to figure out why she wasn't falling asleep, she was worrying about activities during the day, worrying about friends, etc. Very, very anxious kid. So the bed, being awake in bed had become kind of a habitual activity where there was a lot of arousal and a lot of frustration. She then fell asleep, and when she fell asleep, her sleep was very, very well consolidated. But in order to get to school, she had to be up pretty early in the morning, so at around 6 a.m. So the pattern that you can see here is where she's getting pretty good sleep and sleeping in on the weekends, going to bed quite late on the weekends also, and kind of catching up. Over the course of the week, she's not sleeping as much as she needs to. So 8 hours might sound like an absolute gift to us on a regular basis, but to this adolescent, she really needs to sleep 9 to 9.5 hours a night. So by Friday night, she's accumulated almost a full night of sleep debt by the time she gets to Friday night here. And then typically kids will stay up, party, go to football games or dances on a Friday night, then they'll sleep in and catch up on Saturday morning. You can also see that this child was napping, which was taking away from her ability to fall asleep at an adequate hour at night. So insomnia treatment. First of all, sleep education. What is normal about sleep? How much sleep do we need? We need to address worry at bedtime. And we often will do this either by referring a child with anxiety or depression for psychotherapy, or we'll have them keep, if it's not severe and they just tend to, when we don't feel that they have a full-blown or diagnosable anxiety or depressive disorder, then we'll have them use a worry diary. And this can be effective in very young kids and can actually provide an opportunity for some really close parent-child time where they talk about the things that are on the child's mind as they go to bed at night. We address negative, and we recommend the use of a worry diary several hours before bedtime, not right at bedtime, so you don't kind of activate the child at that time. But then you literally put that book away, and that can be very helpful and very calming. Address negative cognition and prediction regarding sleep. So often people with sleep problems will spend much of their day and night worrying about how much sleep they got, how fatigued they are, whether or not they're going to be able to sleep the next night. And this, you can also have the development of kind of a myth about an individual child, that they are the bad sleeper in the family. And you really want to help the family remove those concepts and the language from their daily conversation. Consistent sleep environment. So optimally, a child should sleep in one place every night. So this is also relevant. This is a standard package of cognitive behavior therapy for insomnia for adults as well. Stimulus control, this involves removing the clock from the bedroom, but the clock really becomes a stimulus for arousal and frustration. There's no reason anybody needs to look at a clock in the middle of the night. And I've had children, particularly some of the more anxious kids, weep about having their clock turned around or not looking at the clock. Interestingly, kids become extremely attached to that. And then stimulus control also relates to the bed itself. So we instruct adults and children not to be awake in bed for any extended period of time, or if they have relatively good insight, as soon as they begin to worry or think about how difficult it is to fall asleep or that they're becoming anxious about falling asleep, that's the time for them to get out of bed, dissociate worry, wakefulness from the bed itself. Time in bed restrictions. So we use those sleep logs to determine what the average sleep is across the course of 1 to 2 weeks, and then we limit sleep to that much, because often what you'll get with people with insomnia, they'll spend a lot of time in bed, not asleep, or on some days they'll oversleep, on other days they'll undersleep. So sleep restriction, which also just serves to increase the appetite for sleep, can be very helpful. Want to eliminate naps greater than 15 minutes during the course of the day. There are some people who really are nappers and need their hour and a half and it doesn't disrupt their sleep. But most of the time, a 10 to 15-minute cat nap 1 to 2 times a day can be extremely helpful. More than 15 minutes, though, you get into that very, very deep appetite of sleep, and it's hard to come out. Relaxation therapy, we use a lot of mindfulness-based techniques, various kinds of deep breathing, guided imagery, progressive muscle relaxation, and we try to be very creative in figuring out which channel a particular child will be most accepting of or will be able to use. So a child, for example, who's a soccer player or who plays the piano, using guided imagery that really fits into their high level of interest can be very, very helpful in engaging them and helping them to learn a technique that both serves as distraction and psychophysiological relaxation and letting down. Rule out medical, psychological problems and other sleep disorders. Particularly in adults, it's critical. If an adult particularly has a sudden onset of sleep problems and insomnia, you've got to refer them back to their primary care physician. I have seen too many cases of either a problem with thyroid, onset of cancer, other issues with high blood pressure, sugar, et cetera, that are missed when we're treating a sleep disorder. Eliminate caffeine use. That's really critical, and particularly caffeine after noon. Caffeine has a very long half-life. We also recommend melatonin. And I'm not going to have a lot of time to go into melatonin, but we view it as quite safe. Typically, younger children will recommend it within a half an hour and 45 minutes of bedtime. For an older child or an adolescent who has a delayed sleep phase issue, we'll recommend melatonin 5 to 6 hours before bedtime. It causes a little bit, tiny little bit of sedation and tiredness, but its primary role is to cue the sleep-wake system when it's time to go to sleep. We call it a chronobiotic. So again, treatment, I've touched on most of these areas, so I'm just going to jump over this right now. I didn't touch on sleep hygiene, though, and this is critical. Good habits associated with bedtime. So that means not exercising excessively before bedtime, making sure the bedroom is an optimal environment, not playing video games, not having your right up to bedtime, not having a telephone in the bedroom at all, or a television. I also talked about relaxation techniques. Okay, so again, sleep hygiene. These are some of the critical factors: regular bed and wake times, eliminate caffeine, no stimulating behavior before bedtime, quiet reading or snuggling. Bedtime is a great time for some quiet together time between parents and children. And I'll just say for a moment, a lot of the parents that we see feel so conflicted about putting their child to bed at night and leaving the bedroom. And we all live in this world where we get this narrow sliver of time with our children before bed, in the morning, which is not good quality time, and then in the evening, if we're working long hours, 1 hour, an hour and a half, even 2 hours, just does not feel adequate. So parents often transmit their ambivalence when putting their child to bed at night, and that can be a real problem. And getting parents to reflect on their ambivalence can be very, very helpful because they're transmitting a lot of different messages to their child as they're going to sleep, which is not going to help their child let down vigilance and relax. Circadian rhythm disorders I talked about a bit, so that's a shift in the sleep phase to a later period of time. Most of the time, and that conflicts with academic work schedules, most of the time this is just simply associated with an early school start time, a tendency to want to go to bed later and wake up later, and just not prioritizing sleep. However, we do see biologically regulated or caused circadian rhythm disorders. Those are much more complex. And those are probably a vanishingly small percentage of these 7% of adolescents who have this problem. So sleep and development in adolescence, it's really important to note that the drive for social contact and novelty often overwhelms biological functions, particularly the sleep drive in adolescence. So it's often, well, we want to improve in adolescent sleep and get them to sleep more. It's important to acknowledge that you may be taking away their only time for having some contact with their friends, be it via social media, which we don't necessarily view as optimal. But having that time is critical for them. So it becomes a negotiation, and you may need to give in a bit, or at least say to the adolescent, can you try this for 3 weeks? Okay, if you can't, how about a week? So using some motivational interviewing to get the child to really buy into what you're recommending. Biological shifts in circadian rhythmicity coupled with social stimulation media is just a huge issue. So that this is kind of the major issue of what happens with adolescents. Older adolescents tend to have an increased sleep drive during the night and during the mid-afternoon as well. So older adolescents tend to be more tired. We don't know exactly what it's associated with. Some people have tried to link it to brain development. There have also been a whole variety of studies showing differences in gender. So Brandon, 16-year-old boy, presenting a complaint. He'd missed 30 days of school. A truancy hearing had been scheduled, so his parents needed to get into the doctor and show that they were working on this problem. That's why he presented to us. He does not get up for school, cannot fall asleep at night. Unremarkable medical history. Long history, though, of academic problems. So, getting up and going to a punishing environment or an environment where he just does not feel successful is much harder and can contribute to these phase delays. And then possible history of at least mild depression. So the sleep log is a little bit tough to see, but you get the general concept here that this kid, there are down arrows here. He's trying to fall asleep multiple times at an appropriate hour. He's not falling asleep until 2, 3, or 4 a.m. Then is missing the bus, sleeping in, and then sleeping way in on weekends. So on weekends, in essence, he's resetting his clock, taking a late, long afternoon nap, which erodes his sleep drive at night. So in this particular case, it's kind of more of a behavioral problem. Another child, and I'll talk a little bit about what we'll do in a minute, 16-year-old Hispanic female, maintaining an excellent grade average, single-parent home, 2 younger siblings, generalized anxiety disorder, a lot of worry about sleep, social engagement, obsessive worry about school and getting her homework done. Chronic fatigue symptoms, possible dysthymia as well, shy, and as I said, socially anxious. So this is her sleep schedule. She again tries to get to bed at a reasonable hour, but has not fallen asleep some mornings until 1, 2 a.m. Would wake up, do homework, sometimes wake up very early in the morning, in the middle of the night, do homework, and then sleeping in on weekends, occasionally napping. But you can see this is a grossly sleep-deprived individual who's only catching up once a week. My guess is that this is probably an underestimation of how much sleep she was actually getting, because most individuals really cannot function on 6 hours of sleep without major problems. So what I didn't say, it really didn't have time to say, but it's a fascinating topic, is that during rapid eye movement sleep, there's an essential shutdown of the affective regulation centers of the brain, the locus coeruleus and raphe nuclei, which regulate norepinephrine, serotonin. If you don't get that period of quiescence during rapid eye movement sleep, you can get hypomanic activity, which then leads to depressive, more of a depressive presentation. So when you have this kind of chronic sleep deprivation, and adolescence, this is where she's getting most of her REM, and there's no way she can get her rapid eye movement sleep during early hours. I hope you can see my cursor moving around here. I should have checked on that. But during early hours. So she's missing a large chunk of her rapid eye movement sleep. The body corrects for it a little bit, but not enough. So we generally contract with these kids to follow our instructions for at least 4 weeks and just give up for a little while some of their other high-rewarding activities. And, again, we modify those to the best that we can without undermining how realistic our intervention will be. Chronotherapy. So this is time therapy, so a phase advance. So we'll often say we can't get these kids to fall asleep earlier automatically, but what we'll do is we'll trim their morning wake time gradually over time. That's one approach. You can also use, well, there's no scientific evidence for this, an acute sleep deprivation. There aren't other risk factors that could tip the kid into a manic episode, where you sleep deprive them for one night, and then the next day they should fall asleep early, and then you hold on that schedule. There's also a very challenging but pretty effective approach where you essentially fly the kid around the world. In other words, you delay their bedtime by 3 hours a night, march them forward in time through the course of the day, so that on the first night they might go to bed at 6 a.m., the next day they go to bed at 9 a.m., next day at noon, etc., until they get back to 7 to 8 p.m. bedtime, and then you hold there. Very tough to do. We only do this with some families, but when we can do it and they follow the instructions, it works beautifully. We also use light, so decreasing light before bedtime. Any of you who've camped or been in an environment where you've lost power for a few days, you know that all of a sudden, without internet access and without light in your environment, you go to bed much, much earlier. Temperature, changing internal core body temperature, perhaps with a hot shower, hot beverage, may also help to cue the clock that it's time to go to sleep. And then we use melatonin, as I indicated before, about 4 or 5 hours before the target bedtime. So I talked about chronotherapy, modified sleep schedules, a little bit of weekend flexibility, but you can't let these kids reset their clock every weekend. You need to let them get a little sleep deprived over the weekend, and then their sleep drive during the week will be much higher. Set bed and wake times very rigidly for the parents to follow over the course of a few weeks. I hope their kids follow. Eliminate everything but short naps during the day. 15-minute nap is okay. Eliminate all caffeine. You can use a light box in the morning. Darkness at night is also very powerful. Also some stimulus control. And in some cases, where it really is the case that the child has a learning disability or some other problem, then referral for psychotherapy in addition.
Dr. Lewin, this is all really great information, and we have a bunch of questions coming in.
Sorry, okay.
So can we get to the questions right now? First, we have a question here. How common is snoring in children, and what if a child snores regularly but seems well-rested and does well academically and behaviorally? Is that of concern?
It is concern. Snoring is considered to be a pathology. It means that the child is working harder than they need to at night to move air into their lungs. You can also, anytime snoring can be heard within a child's bedroom or outside, you can imagine the decibel level inside their own head and the impact that may have on their sleep. But snoring is a key indicator of obstructive sleep apnea syndrome. And even the best sleep doc cannot look at an individual and know whether or not they have sleep apnea based on the frequency or the sound of their snoring unless you really hear frank pauses in breathing at night. So a strong recommendation, particularly when snoring is associated with any other kind of daytime behavior problems, daytime tiredness, difficulty waking in the morning, unplanned sleep onset periods during the day, which often means a kid falling asleep in a car ride, but not with friends. That really needs to be evaluated. So a referral should be made to a sleep laboratory for evaluation. Typically, in younger kids, it's caused by large tonsils and adenoids. More frequently, though, in recent years, we've been seeing obese kids with obstructive sleep apnea. But it can be thin or obese kids with some kind of upper airway obstruction.
That's great. This is a quick question. Could you repeat what EDS stands for?
Excessive daytime somnolence.
Okay, great. Now, can you describe the status of the literature on sleep disruption and emotion dysregulation in youth?
Really pretty nascent. We need a lot more work done in this area. There are various individuals who've done work on the convergence of affect regulation, anxiety, and depression in children. But again, the outcome of those studies points to very little in terms of changes in biology or changes in neurotransmitters. So that's why during this talk I really emphasized issues of regulation of vigilance and the association of vigilance, daytime somnolence, or nighttime tiredness and sleep pressure on poor affect regulation, really converging on having an impact on bedtime. Many of the studies have been done. Some of the older studies by Ron Dahl, Kim Chandick, really yielded some variable results. Maybe some decrease in rapid eye movement sleep in depressed patients, but there's a lot more to do in this area. There are a few people around the country doing this research. Still, the group at Pittsburgh is working on this. Peter Franzen, Allison Harvey at Berkeley is doing work in this area, child affect regulation. Candace Alfano, I believe she's at the University of Houston, has been looking at this issue as well. There are some studies on association between sleep disturbances and hypertension and changes in blood pressure dipping at night in individuals with post-traumatic stress disorder.
Oh, that's great information. Here's another one in regards to research. Have there been any studies on whether going cold turkey increases chances of the child developing separation anxiety?
There's one recent study out of Australia, and I'm sorry I'm not going to be able to remember who wrote it, but it is in the past 12 months or so, and they basically showed that all of these behavioral techniques at the age of 12 have not resulted in any kind of other behavior dysregulation, that most of these techniques are pretty successful and don't lead to other problems. It is a good question, though, and I would say that a cry it out extinction technique rapidly instituted in a particularly anxious or depressed child or in a family where there's a lot of ambivalence tends not to work and is probably not the best approach. So these graduated extinction techniques, a much slower approach, is probably much more effective and much more comfortable for a lot of parents.
Okay. Regarding stimulus control, if an 8 to 10-year-old says they can't fall asleep at 11 p.m. or midnight, should they be getting out of bed and walking around?
Well, typically what we help parents, the strategy is to get the child doing something quiet in another part of the house, something that is of high enough interest, they're focused and distracted and not worrying about sleep or having having other anxiety issues. But we typically will have them sit in their bedroom, maybe another room in the house, reading quietly. Perhaps sitting with a parent. Sometimes it will help, particularly with an anxious kid, to put the parent in the child's room while the child is falling asleep, develop what could be a problematic association for the long run, but help the child fall asleep earlier in a comfortable state and then gradually remove the parent from the bedroom. Sleep drive is high in young kids, and typically if you regulate the other times that the child is sleeping, you can gradually advance their sleep time. A little bit of melatonin can also be helpful. With very, very anxious kids with autism or other spectrum disorders, we'll sometimes, or kids with ADHD, we will occasionally recommend an alpha-2 agonist like glomphazine or clonidine to help the child fall asleep earlier at night.
Thank you so much for that information. Dr. Lewin, do you have any other final comments to the audience?
Well, I just want to thank you for your attention. I hope that you will, if nothing else, ask about sleep in your patients on a regular basis. The slides should be accessible. There's my contact information if you do have any questions. And I can provide to the ADAA both a sleep log that you can download as well as a list of references that you may find helpful.
Thank you, Dr. Lewin. And thank you, everyone, for attending this webinar. We didn't get to all of the questions, but you'll receive an email to let you know when a recording of this webinar will be posted on the ADAA website. We hope this was helpful. Please let others know about this series and consider making a contribution to ADAA. Thank you again, Dr. Lewin.
Thank you.